Hello everyone, and welcome to this audio podcast. As part of the series, the Papillae Sirocco, as part of the Papillae Sirocco series. This audio podcast is part of a Labostix Communicado, and an audio podcast is part of a Squadron Kamikaze, and an audio podcast as part of a Storm Labostix production. In this audio podcast, a little bit around in around sort of the in around perhaps one of my main intrigues in around HUS. In around HUS, Haemolytic Uraemic Syndrome is the laboratory tests and investigations, and so hemolysis and red cell fragmentation are usually evident and at presentation at presentation, although this rarely develops later in the disease, even after where, for example, pediatrics or young people have low platelet counts, and after initial sort of forms of treatment where the platelet count can be restored or can improve. This the hemolysis, unfortunately, and the red cell fragmentation generally sort of the one of the main detriments to patients where they two patients with HUS. In the peer-reviewed works, in the peer-reviewed works, some additional bases in around sort of the symptomologies that lead specialists to prompt specific laboratory investigations. So, for example, where the kidneys are swollen and have a sort of paler sort of color. There's many flea bite hemorrhages on the surface, on the skin surface. So where in the previous audio podcast, in a previous audio podcast as part of this series, there was a mention around petechiae, the terminology petechiae. Petechiae is where children, pediatrics, or young people present with flea bite sort of hemorrhages on the surface, on the skin, or the surface of the skin. And There's also gastrointestinal involvement, which may lead to symptomologies of an acute abdomen with occasional perforation. And there's also where peds can present with issues in around blood pressure, in around hypertension, and then one of the main symptomologies, one of the overarching symptomologies that lead specialists to to prompt specific laboratory tests and investigations is symptomologies around anuria and oliguria, depending on overall glomerular filtration rate and renal function, and again and so coagulation studies, so blood clotting studies, are usually normal, can be normal, with a mildly raised D-dimer investigation, and where the D-dimer titers are in contrast to the disseminated intravascular coagulation, or DIC sort of analyses, disseminating intravascular coagulation analyses. And then investigations such as the von Willebrand factor, VWF levels, are usually markedly raised during acute illness, while analysis may or may not show ultra large may not show analysis may or may not show sort of large multimers, meaning where for example where more than one investigation around von Willebrand factor or VWF can show varying analyses, and where specialists would then request would then prompt specific more specific investigations. Poor prognostic features at presentation can include a high neutrophil count, severe thrombocytopenia, so low platelets, severe thrombocytopenia is uncommon, but prolonged thrombocytopenia for more than 10 days is associated with a long-term sort of nephrology sort of picture. And factor eight being part of the clotting cascade, and a sort of for being a main clotting factor to help blood form a clot where applicable. The factor 8 levels do not correlate with the clinical outcome, and the peer review works. In the peer review works, there is an overview in around the hematological basis of in around HUS. So, for example, in around the hematology, the sort of hematology investigations, there's full blood count, which highlights an anemic picture on presentation. There's coagulation that highlights activated prothrombin time, and prothrombin time are both normal, which suggests at the same time can suggest sepsis rather than HUS and thrombocytopenia or TTP. And then there's also platelet and fibrin microthrombi, which is evident with the renal microvasculature. There's thrombocytopenia, which is universal at some point in the illness, and then hematinics. So hematinics being B12 folate and ferritin investigations tend to highlight there is a variability in iron levels or iron titers, and direct sort of transfusion hematology investigation, referred to as a direct Coombs test or direct Coombs investigation, is generally negative. Plasma haptoglobin levels is decreased owing to red blood cell breakdown degradation and raised fraction degradation. There's in around investigations around fraction degradation products or FDPs. There's normally a raised FDPs, and there is a slightly elevated D dimer. There have been for example, peer-reviewed works and published works to inform, for example, that relying on D dimer alone is and should not be a basis to diagnose a young person or ped that may on first basis may look like that they may look and present with the symptomologies around hemolytic uremic syndrome. However, a D dimer investigation with additional hematology and coagulation and sort of transfusion based investigations can help sort of help inform, and D dimer alone cannot, where some peer review works in some peer review works have informed that D-dimer investigation is required in HUS, but is not the standard. It's not a laboratory investigation on its own that can help diagnose a recipient a recipient with HUS. There may be at the same time there may be a microcytosis, so the red cells and the red cells under morphology would potentially look smaller. So the patients or recipients' red cells may have to work would generally have to work harder to ensure appropriate general homeostasis in context of pathophysiology and physiology. Red cell enzymes and osmotic fragility investigations are normal. Reticulocyte count is also shows sort of elevation. Reticulocyte count with a direct Coombs test and a D-dimer are perhaps in around the hematology around HUS are perhaps the three main investigations that are required to inform specialists that a patient or recipient will excuse me will have hemolytic uremic syndrome. The peer review works has an overview in around the hematology. It summarizes the laboratory tests and investigations according to the symptomologies. And there is also in the peer review works sort of a histological stain which highlights around the glomeruli sort of where there's where the fibrin around the glomeruli show platelet fibrin thrombi in around the glomerular capillaries, and where the histological staining informs that a patient has HUS with hemolytic uremic syndrome with a microangiopathic disorder, and so that draws this audio podcast to a close. This has been an audio podcast as part of a Papillae Sirocco as part of this Papillae Sirocco series. An audio podcast as part of a Labostix Communicado, an audio podcast as part of a Squadron Kamikaze, an audio podcast as part of a Storm Labostix production.